Actually, since Antonio Spanevello had to go back and he will come later today, it's my pleasure to introduce Arzu Yorgancıoğlu. A few words. Arzu is involved in GINA, I guess, since a few years, and I'm very, very pleased to say that actually she is finally the chair of GINA, which I think is one of the most important roles nowadays in our field. Arzu is coming from Turkey, and I have to say that nowadays she is the chair, and she is a woman. The scientific chair is a woman too.
Yes, yes.
So even in this sense, I have to say that GINA is respecting what all we wish.
Thank you.
Thank you, Arzu.
Thank you very much, Walter. I'm very pleased to be here. Thank you very much for the invitation, my dear friends Flavio and Walter, and the organizing committee. Being a member at large of Interasma, I'm very proud of the scientific level of this Congress. So I will give you an update of GINA 2024. These are my conflict of interest. I have some governmental interests, WHO, Turkish Ministry of Health for GARD, ERS and GINA as well. I bring you the greetings of GINA Science Committee members and the members of the board. And Matteo is here as well as a member of the Science Committee. Whenever we make a presentation about GINA, we inform them and they send you the greetings. So all of you know, I'm sure, GINA is a strategy report and it was founded in 30 years ago. We have celebrated 31 years this year. We have celebrated the 30th anniversary of GINA, and it is updated every year by the Science Committee. And this update has been released by World Asthma Day. This year, 7th of May, was the day of the release of this. So, what are the news? What is new in GINA 2024? First, diagnosis of asthma. We all know that overdiagnosis or underdiagnosis of asthma are very common, and respiratory symptoms are non-specific. So we need to make spirometry, but it's a fact that spirometry is not available in every part of the world, and it's not in good quality. So GINA this year put peak expiratory flow, but saying that it is less reliable than spirometry, but better than nothing. So I'm going to show you the algorithm of diagnosis. Here you can see we add peak expiratory flow measurement again after years, because we are aware that spirometry is not accessible or available in many countries. That is the thing. We need to struggle to have a good qualified spirometry in each country of the world. So this addition of peak expiratory flow is a new thing. And the other one is the bronchodilator responsiveness. You know that in untreated asthma patients, we have, after the bronchodilator test, we have a quick symptomatic relief and rapid onset on bronchodilator. But we can do it randomly, and that time it has limited utility, especially if long after disease onset. So asthma is variable. ICS containing treatment, if patients is on treatment, increase pre-bronchodilator FEV1 and decrease bronchodilator responsiveness. We need to keep this in mind. So the current ERS ATS criterion for bronchodilator responsiveness is in clinical practice is an increase in FEV1 or FVC from baseline by 12% or 200 milliliter. And ERS ATS Technical Standard Committee proposed changing this ratio to an increase by 10%. So GINA has discussed this finding a lot, almost half a day in person and also online. And after it resulted that based on the data for mortality, it is not yet widely compared with the other diagnostic tests of asthma. And this is the technical committee, but this is a clinical finding. So this technical committee did not advocate adoption of this change for clinical practice. So GINA will review this again, of course, when more data are available. For GINA, if we are going to make a recommendation, there has to be at least 2 randomized controlled trials and the approval of the authority. Otherwise, GINA cannot recommend a change in the recommendations. You all know that asthma is treated as a recurrent acute disease, and it's a real burden to patients, family, health system, and economy, and the risk of asthma mortality. And also we have a cumulative risk of adverse effects of oral corticosteroids with even 4 or 5 lifetime courses. And asthma morbidity and mortality are largely preventable. So we emphasize, we underline the goal of asthma management. The goal is to achieve best possible long-term asthma outcomes for the long-term symptom control, long-term asthma future risk minimization, which may include no exacerbations at all, improved or stable best lung function, no requirement of maintenance for oral corticosteroids, and no medication side effects. Assessing symptom control currently is not enough. We have to take into account of the future risks. So this is a nice flower figure. We put it in the last year's GINA update 2023, emphasizing the health of environment, of the health of our planet, because this is very important. For this patient, which is the right medication? First of all, you need to know which inhalers are available in that country. This is important. If you don't have that inhaler, you cannot prescribe it. And at the left leaf, you can also check if the patients can use this correctly. And the bottom leaf, is the patient satisfied? And this is a new leaf. Which of the inhalers has the lowest environmental impact? So this is a public health message of GINA. When you are choosing an optimal inhaler, please take into account that it is safest for the best for the patient as well as the planet. And this is the asthma treatment is not set and forget thing, not just medications. So you can see here, we need to assess many things, including comorbidities, adjust the treatment according to these modifiable risk factors and comorbidities, and then review it in every visit of the patient. This is our famous GINA 2024 treatment figure. We put the date also here because sometimes it has been mixed by the years. GINA 2024. We have 2 tracks, as you can see. The difference between the tracks is the reliever. In the first track, which is the preferred track, the reliever is as needed low-dose ICS formoterol, which is called AIR, anti-inflammatory reliever. We need this. And for the second track, you can see that the reliever is as needed SABA. We don't want people to use SABA, but if the patient can use in other combinations of ICS LABA rather than ICS formoterol, they can use SABA. But we definitely underline this, that the patient could be very much in compliance with the maintenance treatment, not to be exposed to SABA-only treatment in the track 2. And you can see this is the track 1. We merge step 1 and 2, and the recommendation is as needed only low-dose ICS formoterol. We have step 3, step 4, and step 5, increasing the dose of maintenance, but the reliever is as needed ICS formoterol. And the track 2, when step 1, take ICS whenever you take SABA. It's not practical. Patients do not use it, do not use different inhalers, especially they use the bronchodilator, they don't use the ICS because of the corticophobia. And in step 2, low dose maintenance dose and as needed SABA. I'm I'm sure that you will agree with me that mild asthmatics who have very little symptoms do not use ICS as a maintenance. So step 3 for low dose, medium or high dose ICS LABA, and the reliever is SABA or as needed SABA, but it is only available in some countries of the world. This has been put into recommendations by the study of Alberto Papi for ICS SABA. And these are the other controller options, which we do not emphasize them very much. So GINA made a fundamental change in 2019 regarding saying that SABA should not be used as the only treatment in each step of the GINA treatment figure, because we know that people with mild asthma can have severe exacerbations, and up to 27 asthma deaths are in patients in mild asthmatic with occasional symptoms. So we have to take this into account. And exacerbation triggers are unpredictable. And also we have oral corticosteroid courses increase the cumulative risk, even if they use it 4 or 5 times lifetime. We have evidence for this. And regular use of SABA, even for 1-2 weeks, is associated with increased airway hyperresponsiveness. So it can lead to vicious cycle by encouraging the overuse. And overuse of SABA, we have learned from Sabina trials that it is associated with the high rate of exacerbations and high rate of mortality. And also another issue is starting the treatment with SABA makes the patient regard that it is my primary asthma treatment, but it is not. So it was a conflicting recommendation, and poor adherence with ICS is almost inevitable. And the blue one's good because you can just have a couple of squares and get back to what you are doing, the patient says, but it's not real. And I'm going to show you, we have a very strong evidence for a more effective and safe alternative than SABA alone. It is ICS with as needed SABA or as needed ICS formoterol, and we call them as AIR. This is the data near 10,000 patients in mild asthmatics, step 1 and 2, as needed low dose ICS formoterol compared with as needed SABA, compared with maintenance dose, low dose ICS SABA plus as needed SABA, that it works better than these two approaches. Here is the proof that as needed only ICS formoterol compared with as needed SABA decreases the exacerbations 65%, and as needed ICS formoterol compared with daily ICS and as needed SABA still decrease 37% of the exacerbations. And this approach in mild asthmatics is approved in more than 50 countries and recommended in asthma guidelines of 32 countries. We believe that it should increase more and more. For step 3 and 5, we are used to it because it's a bit older approach and we use it. In this, also there are some comparisons. Here you can see the comparison with the same dose ICS LABA, with the higher dose of ICS LABA, comparing with conventional best practice, and you can see the onset of action between terbutaline formoterol and budesonide formoterol in the ratio of the severe exacerbations. So we have a lot of proof that it's just not an inflammatory, but they are also a reliever. So track 1, and also I would like to share with you the simplicity of this track 1. When it is step 1 and 2, you recommend the patient just one inhaler. Use it whenever you need it. In step 3, again, same inhaler, take one inhalation or twice inhalation a day and take when you need it. For step 4, you can increase the maintenance dose, but reliever is the same inhaler. So at the 4 steps of GINA, you give only one inhaler, which is easier to understand or to educate the patient. Here you can see for budesonide formoterol and beclometasone formoterol, you can see the recommended doses. And people are asking how much we can use. The maximum total dose of formoterol is, as you can see here, is 72 micrograms. So 12 inhalation is recommended by both of them because of the formoterol size. And here, as I have mentioned, for patients over 12 years, maximum total in one day dose is 12 inhalations budesonide formoterol. And very few patients need this amount of reliever in the studies of this. This is track 2. If you would like to use the track 2, you're going to give the take ICS whenever taken, low dose maintenance, step 3 and step 4. But you need to give 2 different inhalers for mild patients. Same inhalers, but change one to regular use. Switch to new inhaler for regular use, continue as needed inhaler, and switch to higher dose inhaler. It's a bit more complicated. It's a bit more hard to educate the patient. And this is a table of starting the treatment for the initial treatment. You can see the symptoms and the lung function here. If you would like to start track 1, these are the preferred options. If you are going to start track 2, these are the... So this table is better to understand and better to use for clinical practice. It is the same as I have shown you, the main treatment figure, but how to start the treatment, I think it will make you easier. So for the difficult to treat asthma, I would not go into detail because this is not the task of today's meeting. And we are preparing the short GINA 2024 guide on difficult to severe asthma. And they have included GINA decision tree. This is, I'm sorry that the fonts are really small, but we have pop-ups for this. In order to assess the patient, if the patient will need a biologic, you need to look for the symptom exacerbations, incorrect inhaler technique, suboptimal adherence, comorbidities. If the patient is obese and she or he doesn't lose weight, if he is a smoker, if not quit smoking, you cannot have a complete control. So we need to deal with this modifiable risk factors. Once we made the education and asthma is still controlled, then it is severe asthma. And then maybe when the asthma is still, it is controlled, you can consider stepping down, but does asthma become uncontrolled, then you can say that it is severe asthma, and then you can think of the biologics. Which biologics we have? We need to find that if it is a T helper 2 or T helper low phenotype. The best thing is to look at the blood eosinophils, pheno, sputum eosinophils, if you can make it, allergen-driven, and you need to repeat it, not one measurement, maybe 3 measurements, because asthma is variable and the biomarkers are variable. So we need to consider the adherence test. If the patient is not type 2 airway inflammation, then we need to go in detail in the diagnostic tests. We need to avoid exposures and also maybe bronchoscopy, high-resolution CT. We can add LAMA, low-dose azithromycin, anti-IL-4R alpha, anti-TSLP. We have studies for T helper low patients. And please take this into consideration that at last resort, add on low-dose ICS or OCS. Here I'm going to show you the biologics that is recommended in GINA. In order to select, please look at the anti-IgE for severe allergic asthma, sensitization or specific IgE, total serum IgE and weight within dosage range. We have a table, and exacerbations in the last year. So you can, if the patient has higher blood eosinophil, higher pheno, allergen-driven symptoms and childhood onset asthma, and the biologic will come as omalizumab. And anti-IL-5 and anti-IL-5R, anti-IL-4R dupilumab, and anti-TSLP tezepelumab. We have the higher blood eosinophils there, more exacerbations, and here for Benra, Mepo, and Resley, nasal polyposis is important. For Dupi, higher and higher rates, and also TSLP higher, and we have some evidence with the T helper low inflammation. And this is for continuing to optimize the management. I'm not going to go into detail. And please review the response at least 3, better 6 months, because it takes time the inflammation to improve. If good response to type 2 targeted therapy, re-evaluate the patient after 6 months. But first, consider decreasing or stopping OCS. And if asthma is well tolerated, consider reducing the maintenance ICS LABA dose, but do not stop maintenance ICS LABA. And re-evaluate the need for biologic therapy and order of reduction treatments based on the observed benefit, potential side effects, cost, and patient preference. And how we can step down the patient if he or she is stable for 3 months. But if the patient has exacerbation risk factors, like a severe exacerbation in the past year, step down only with close supervision. Choose an appropriate time, make a deal with the patient, and engage the patient in the process. This is very important, and we need to provide clear instructions. Do not stop ICS-containing treatment in those patients. And this is the same for these recommendations. And this is a table of low, medium, and high doses of various ICS. This does not imply equivalent potency. So we need to keep this in mind. And remission of asthma, a couple of slides, because GINA has been asked to say something about remission for the recent 2 or 3 years. And GINA discussed this a lot. And what we put in the strategy report, that we need to be aware that children and adult remission are different. Clinical and complete remission are different. And we have multiple definitions in the trials that has been done, and no validated tools for assessment of symptoms over periods longer than 2 weeks. This is so important to talk about remission. Remission from childhood wheezing or asthma off treatment. It is possible in children to be off treatment, but for adults, we need some evidence. And patients and caregivers often ask their child will grow out of their asthma. They will finish, they will get off of their asthma. They want this message, but we cannot give them this message. Asthma often occurs. Remission is not cure. We need to tell the patients and the parents for this. For the remission in adults, it could be on treatment. We have very good data on biologics to have this remission. And the data mostly for severe asthma on biologic therapy. So remission is also seen in non-severe asthma with ICS-containing treatment, and sometimes spontaneous. That is in the definition of asthma. We need research. That's the conclusion of GINA. Multimorbidity, anxiety or depression, moderate or severe persistent airflow limitation. So evidence about the goal setting tells us the treatment goals for patients should be personalized and achievable. Be aware, encourage inappropriate step-up therapy, treat first modifiable risk factors and comorbidities, and GINA Track 1 regimen with ICS formoterol reduces exacerbations with lower ICS dose. Do not forget this. So I will just come back to the goal of asthma management. Please take into account the best possible outcomes for these patients. Another difference is the role of FeNO. We have put some statements about it and risk assessment about this, but we say that main role remains in helping to guide treatment decisions in moderate or severe asthma. And allergen immunotherapy may be considered, as you know, as add-on therapy for adults and children with asthma, the only intervention with both an immune-modifying effect and long-term efficacy on allergic responses. We are aware of this, and most of the evidence is with house dust mite, grass pollens in patients with allergic rhinitis, and I believe we will discuss this later. And we can use subcutaneous, we can use sublingual immunotherapy, and there are indications for this you can take into account. And the other important thing is we have included cough variant asthma because we have traveled a lot to China and we see a lot of trials, and cough variant asthma is very much important in China and they have very good trials. And in order to frame this, we put cough variant asthma common in some countries, especially in China. Spirometry may be normal, diagnosed by bronchial provocation test, and treatment is like for asthma with inhaled corticosteroids. And I have touched bronchodilator responsiveness. For Montelukast, we have consistent evidence to advise patients and caregivers about potential neuropsychiatric effects, and there is an increased attention in social media, and pulmonary rehabilitation, of course, is an option for the chronic asthmatic patients. You can see that the global catastrophe of preventable asthma deaths is low and middle income countries, so we need to deal with this. And oral bronchodilators are not recommended. Being a GINA chair for the 1.5 years, I have visited many African countries and many low-income countries, and I saw that there are no inhalers there. There are no inhaled corticosteroids, even inhaled bronchodilators. The only one they have that the oral bronchodilators and oral steroids. So we feel that we need to put this, that oral bronchodilators are not recommended, and we need to advocate for global access to essential inhaled medicines to all. That will be a public health issue for GINA, and GINA will be struggling for this to having inhaled corticosteroids available in those countries. Also, another situation we have experienced is the nebulization of SABA. It is also not recommended because it is associated with increased risks. It is associated with risk of asthma mortality, and also we have experienced during COVID times increased risk of transmission of infection. So we need to use some space providers, quicker relief and less risk. So GINA's main goal this year will be, as in parallel with WHO message, leaving no one behind, especially the ones with low and middle income countries, who in these countries the mortality rate or the mortality of asthma deaths here is 96% in those countries. So we need to struggle, and I believe, Walter, we are missing you here. These are the GINA advocates. He arrived late. We have this photo, and we have GINA advocates in almost every country, and they are the advocates of GINA for disseminating and for implementing GINA recommendations, and they are the one who get the first update and give their feedback, and then we revise it according to their suggestions, and we release World Asthma Day update. Thank you very much for your attention.